Acquired hypothyroidism is a common pediatric condition which presents with a wide variety of clinical manifestations. Unfortunately, the diagnosis is not considered in most situations, resulting in extremely delayed identification and compromise on different bodily functions. Timely assessment and management is essential for achieving a successful outcome in these children. So we'll go forward initially with the when, why and how of acquired hypothyroidism in children. So when do we suspect hypothyroidism? And I think most of us know if there is significant growth failure, delayed development or coarse skin, we do think of congenital or acquired hypothyroidism. But what we identify is a child like this who is presenting at an extremely late stage with so much deficit, both growth and intellectual wise, that nothing much can be done in this situation. So we'll go forward some of the rarer presentations which should alarm us about the possibility of hypothyroidism. So we have a 4-year-old male who presented with motor delay, and we can see calf hypertrophy in this child, which is looking like a pseudo hypertrophy, and the child's CPK was done, which was 1000, and a diagnosis of Duchenne's muscular dystrophy was considered when the TSH was more than 100. So it was actually a situation of hypothyroidism, which was misdiagnosed as Duchenne muscular dystrophy. 7-year-old girl with both Thelarche and menarche, so very rapid onset of breast development and periods. The child was short and evaluation showed a large ovarian cyst. So the girl was diagnosed as an ovarian cyst, but when the child was referred for evaluation, it was very clear that this was an unusual case of precocious puberty, in the form that we have very close onset of breast development and periods, and the child is short while most children with precocious puberty should be tall. So when we examined the child, looked at her classical features of hypothyroidism, and TSH was very high. 10-year-old boy with dyspnea, and this picture was identified, diagnosed as pericarditis because of the large heart, but when somebody did TSH, it was more than 100. 15-year-old girl with delayed puberty, no breast or pubic hair development, LH and FSH very low, and prolactin level was found to be high. A diagnosis of hyperprolactinemia was considered, but when TSH was done, it was diagnosed to be very high. 10-year-old boy with drowsiness, hyponatremia, hypokalemia, high urinary sodium and urinary osmolality in a euvolemic child resulted in the diagnosis of syndrome of inappropriate ADH secretion, was advised through distinction, but there was further worsening, and at that point of time was diagnosed as central hypothyroidism. So hypothyroidism is a very pleiotropic condition which presents with a wide variety of presentation, should be suspected in a child who has pubertal disorder, both delayed and early puberty, particularly if it is associated with short stature. If there is unexplained encephalopathy with hyponatremia, myopathy with pseudohypertrophy, and respiratory distress in the setting of cardiomegaly and pericardial effusion. So we need to keep our eyes and ears open towards diagnosis of hypothyroidism, because it's one of the most reversible form of condition which will respond dramatically to an extremely simple and very, very inexpensive treatment which is available to us. So why does a child develop hypothyroidism? And if we go back to our hypothalamic period-free thyroid axis, the vast majority of cases is primary hypothyroidism, and in that regards, autoimmune thyroiditis is the most common cause responsible. Even in the endemic area, it is the commonest cause of acquired hypothyroidism in children. Typically presents with thyromegaly, which often could be bossulated and relatively firm. Iron deficiency is a relatively uncommon condition. Autoimmune associations of hypothyroidism are also often found in the form of premature ovarian insufficiency, celiac disease, or type 1 diabetes. Hypothyroidism should be excluded in every child with celiac disease and type 1 diabetes. Central hypothyroidism is extremely rare, usually presents with a combined pituitary problem, and therefore we need to evaluate carefully, especially ACTH deficiency, but also gonadotropins and growth hormone deficiency in individuals who have central hypothyroidism. Resistance to T3 is extremely unusual, and should not be considered in most cases. Finally, coming on to management of these children. So screening for hypothyroidism should be done in every child at birth. Those who have autoimmune associations like type 1 diabetes, celiac disease or premature ovarian insufficiency, and in the presence of genetic associations like Turner syndrome, Down syndrome and Klinefelter syndrome. We won't go into detail because it's already been discussed. In individuals who have a low free T4 level, a possibility of central hypothyroidism should be considered if the TSH levels are low, and primary hypothyroidism if the TSH are high. If the FT4 is normal and TSH is high, a possibility of subclinical hypothyroidism should be considered. We also need to consider that during stress and non-thyroidal illness, we should not routinely assess thyroid functions unless very clearly indicated, because that can cause confusion in terms of evaluation and management. So we'll now have a first child, 6-year-old boy with short stature, who presented with a total T4 levels which was 60, which were low as compared to the normal range, and the TSH levels were normal. So what's the diagnosis? Does the child have central hypothyroidism? It's extremely important if we have a discrepant picture of low T4 and a normal TSH, which may indicate towards the possibility of central hypothyroidism, which is an unusual thing. It may be better to go ahead and look at FT4, which is an indicator of actual levels of thyroid hormone and which were found to be in the normal range. So this was not central hypothyroidism, but a case of probably low level of thyroxine binding globulin. What about this child, 10-year-old boy with septic shock, FT4 of 18 and TSH of 9.2. So mildly elevated TSH with high normal FT4. Does this child require treatment? No. This is a classical case of non-thyroidal illness. We should not be considering treatment unless the TSH levels are substantially high or the FT4 levels are low. Best to repeat TSH after 4 weeks, which was normal, and we don't need to do anything as this is a non-thyroidal illness. 13-year-old girl with obesity, and this is the common presentation which we are seeing. Height is normal, TSH is borderline elevated. And what do we do? There is no thyromegaly or family history, and we did a FT4 levels which were normal. So whether this child who looks like a normal growth situation, which goes against hypothyroidism, has a borderline TSH and a normal FT4 required treatment. Now we see often in children with obesity that mild elevations of TSH may be observed, which are in fact the effects of obesity and hypothalamic dysfunction and not the cause of obesity. These levels usually normalize over time and do not require routine supplementation in most cases. So if you actually look at the thyroid functions in children over a long-term period from this study from Israel, what we can see that even those who have TSH levels more than 10 tend to stabilize at this level, and they have considered a 7.5, especially in girls who seem to have a higher risk of developing abnormal thyroid functions later on. But essentially what it is telling us that we need to be careful in not unnecessarily starting treatment at early stage of children who have a borderline thyroid function in this setting. So if you have a TSH which is more than 5, which is confirmed on 2 occasions, we should look at if the level goes beyond 10, there is no confusion, treatment should be started. But if the TSH is less than 5 to 10, we should look at FT4. If FT4 is low, this looks like a central hypothyroidism for which treatment has to be instituted after correcting cortisol deficiency. If it's normal, we have to look at possible indications for thyroid treatment, including TPO positivity, thyromegaly, and be more proactive in treatment if there is a girl child in this setting. If they are present, we should consider treatment, otherwise follow-up is what is required. So the key message is most children with TSH between 5 to 10 do not require treatment. Best to get a TPO antibody done. If that antibody is positive, start, otherwise wait and watch is the best policy in this regards. General principle of treatment are to use thyroxine at a dose of 1.6 microgram per kg per day. No benefits of adding T3. There's a very narrow therapeutic window which is there, As far as thyroid functions are concerned, there's a huge brand variability, and there needs to be a minimum gap of 30 minutes between food and thyroid hormone supplementation. A few practical tips that should be given: empty stomach. Light exposure should be avoided because that can further aggravate the abnormality as far as thyroid tablets may become degraded. The thyroxine tablet has a long half-life, and if a child has missed a tablet, they can take 2 tablets subsequently, and fractionation of doses should be avoided. So we have a 12-year-old girl with TSH more than 100, started on 100 micrograms of thyroxine, complains of severe headache and irritability and worsening of school performance. This is a common condition which we encounter in children who have long-standing hypothyroidism, who are adjusted to the dose, and suddenly we start off with a high dose. The child becomes in a problematic situation, and therefore we should use gradual replacement in most settings. How do we monitor a child on thyroid replacement? For a primary hypothyroidism, TSH is the best strategy, and 0.3 to 3 is a reasonable target. In secondary hypothyroidism, TSH has no role, and FT4 should be maintained in the upper normal stage. The thyroxine requirement is usually lower in individuals with secondary hypothyroidism or puberty defect. Should be monitored every 3 to 6 monthly, and once we are changing the dose, we should do it after 6 weeks of modifying the dose. So we have a 14-year-old girl with hypothyroidism taking 250 micrograms of thyroxine, good compliance. TSH still is very high. So what's wrong? We also look further. The child is actually having a lean phenotype, is anemic, and we evaluated TTG was strongly positive. 11-year-old girl with lethargy, FT4 was found to be low and TSH was also low. Diagnosed as hypothyroidism, started on 50 micrograms of altroxin, suddenly went into altered sensorium in shock. So what really went wrong? The problem here was this child actually has central hypothyroidism, and in this setting we did not evaluate cortisol level, and once the thyroid levels were corrected, the metabolism increased and the child suddenly went into shock and abnormalities in that regards. So the key messages that are there with regards to hypothyroidism include that we should think thyroid in a wide variety of situations, including pubertal disorders, respiratory distress, ovarian cysts, myopathy, and pericardial effusion. Look at both FT4 and TSH because central hypothyroidism will otherwise be missed. If TSH is marginally elevated between 5 to 10, be very cautious in starting treatment because you will be labeling the child for life with thyroid disorders, and there is a need for regular follow-up and treatment.